So thank you to everyone for joining. This is the National Fellow Online Lecture Series. It is sponsored by AMSSM Online Fellows Education Subcommittee, the AMSSM Education Committee, and the AMSSM Fellowship Committee. So this is supposed to serve as an adjunct to your individual program's education program. It's supposed to provide fellows with direct access to educational experience with experienced AMSS members, and at times invited guest experts in a variety of formats. And mainly it's to help assist in your CAQ exam preparation. As always, the meeting will be recorded and uploaded after the meeting to the YouTube channel, so you can always refer back at a later date. Just a couple housekeeping rules, as we all know by now. Please mute your microphones so that there's no background noise. And if you could also turn off your videos, that just helps the web function better. If you have questions, please submit them through the chat, and we will try to get to as many questions as we can at the end. And after the program, there will be a link to the survey at the end of the chat. Please fill that out so that we can continue to bring good content and things that you want to hear about, okay? So, without further ado, I am going to introduce Dr. Chris Hogrefe. Dr. Hogrefe is in the Department of Emergency Medicine at University of Iowa Medical Center. He did his undergrad at Creighton University before going on to the University of Iowa College of Medicine, and he did his emergency medicine residency in the University of Iowa Hospital at Iowa City as well, and his primary care sports medicine fellowship at Iowa City as well. He currently serves as an assistant team physician for the Chicago Cubs, and prior has served as an emergency on ice physician for the Chicago Blackhawks and a visiting medical consultant for the National Football League. He started his career at the Department of Emergency Medicine in Iowa City, and then recently was at the sports medicine department at Northwestern Medicine prior to returning to Iowa City. So Dr. Hogrefe has published numerous papers and given numerous presentations related to sports medicine and emergency medicine. And in 2020, presented at the Society for Academic Emergency Medicine on epidemiology of fractures in the United States emergency departments, which is very apropos to our lecture today, which will be traumatic foot fractures. Just a couple of fun notes. Dr. Hogrefe is a Chicago Cubs season ticket holder, and he also, according to his bio, owns 127 Air Jordans. I'm not sure if that's still the correct number or if it needs to be updated.
Oh, that's way off, Dr. Robinson. That's way off. There 206 arrived in the mail yesterday.
Wow. Okay, so I am going to stop sharing my screen, and Dr. Hogrefe, you can take over.
All right, let me know what you see, okay? So hopefully you see, let's see, let's share that screen. So what do you see?
X-ray.
Okay, you don't see the presenter notes or anything?
No, just the X-ray.
Excellent. All right, well, that introduction was way too much. Those are just titles. I happen to be a guy who's been in the right place at the right time and happen to have my dream job taking care of a baseball team. Although this year it hasn't been quite the same dream as it has the previous 7, but I won't belabor that point. It is an honor and a privilege to be invited to speak. Again, I had this honor last year, and hopefully I do not disappoint those who were brave enough to attend in person today and those viewing on YouTube down the road. Just as a bit of background, every time I give a presentation, I ask for audience participation. That's very difficult on Zoom, I've learned over the last 18 to 20 months, but I'm hoping you guys will humor me and chip in and see if we can learn some things together. So with that, we'll get started, but I always start my presentations with a bit of music. So I'll ask you to name the song, the artist, and bonus points for the album. Are we ready? Now I gotta cut loose, foot loose, kick off the Sunday shoes. Somebody out there in the chat had this is Kenny Loggins. We're talking about foot fractures. I figured we'd play a little Footloose. Fun side note, Kenny Loggins is actively lobbying, or so I've read, to be a part of the Top Gun sequel that's been delayed a bit by the pandemic, so maybe he'll come back in. Footloose was that oddly themed movie where a town banned dancing. I totally understand that one, but nonetheless, fairly popular. Kevin Bacon, you may have heard of him. And it was so popular that exactly 10 years ago, they remade this movie. I have no idea why. I think we've run out of good ideas at times. Juliana Hough starred in that one. That was probably sufficient to get some people to the theaters. So we'll talk about a few loose bones in the foot as we move forward. Just for the sake of completeness, so I am employed by the Chicago Cubs, but I have no conflicts of interest as it pertains to this particular presentation. Here are our objectives. We're going to touch on some epidemiology of foot fractures and discuss the most common traumatic foot fractures that we will encounter, whether it's in a primary care clinic, the emergency department, where I just left, or on the sideline in the training room, etc. Going to toss a few pearls your way with regard to physical exam and how to identify these injuries on plain films. We will touch on various imaging modalities at times, along with the treatments and disposition for these patients. Hopefully at some point in time, you laugh during this presentation. If I have accomplished that and nothing else, then I will consider it a success. And if you have to laugh at me, you will far be it from the first one to do so, as I received no fewer than a dozen texts today telling me that the picture in the announcement and introductory slide from Dr. Robinson is at least 10 years old now, but we're going to roll with it because I don't want to take a new picture. All right. Now, the other thing I like to do during presentations is to give you a break from the monotony of having to hear me talk for 40 minutes or so. So we're going to break up that monotony with a little, hopefully interactive game. So feel free to take yourself off mute and shout out answers. There'll be questions throughout the way, hopefully making it interactive, but particularly with these ones, because we're going to play a little game. We're going to play a little game of Guess Who? Guess who the athlete with a famous foot fracture? That, of course, was the Who, playing Pinball Wizard. Fits the theme of Guess Who, excuse me. So who's this?
Zion Williams.
Hey, participation, bonus points. Thank you. Yes. Anybody read the news lately?
Case of the fifth metatarsal fracture.
Oh, he shows up and says, you know, yeah, I'm not going to be ready for training camp. I'll be ready for the start of season. I just had surgery on my fifth metatarsal fracture. That caught almost everybody off guard. Apparently he had the surgery on his own and reportedly worked in lockstep with the team. I'm not trying to break news or speak out of turn. That's just what I've read. So if it's incorrect, I apologize in advance, but caught everybody off guard, especially for a guy who blew open his Nike shoe on national television while at Duke. All right, bonus points for this one. Any Mets fans out there? Dr. Robinson, you might know this one. Anybody know who this is? He was having a good year. He was keeping them in the playoff chase. Then his number was given to Javi Baez when they traded him from my team. As a side note, you want to see utter despair on a child's face. I have a 13-year-old son who turned 13 on trading deadline day. This kid has grown up a Cubs fan his entire life and was in the World Series parade and was at Game 7 in Cleveland. And he watched all of his favorite baseball players one by one get traded on his birthday. Oh, it crushed me. But back to work here. This is David Peterson. David Peterson was rehabbing from an oblique injury earlier this year in July, and he was walking through the clubhouse, tripped, fell, suffered a fifth metatarsal fracture as well. So he's done for the season. Not only did he lose the rest of his season, apparently he lost his number. And then everybody knows this one. Come on. He's a Hall of Famer. Somebody.
Frank Thomas.
Yes. And typical White Sox fashion. Look at his pants. Clearly a patch job right here. They can't even afford good, clean pants down the south side. So this is Frank Thomas. Frank Thomas had an interesting injury, and I think it puts our presentation today in a bit of perspective. So in 2006, Frank Thomas sued two of his team doctors, the orthopedic surgeon and the primary care team doctor at the time. And the story goes, this is not firsthand information, this is me reading Tribune articles, etc. It So he was playing the A's and he fielded a ground ball and he felt some pain in the dorsal aspect of his foot. Evaluated by the orthopedic surgeon within a couple of weeks of the injury because the pain wasn't going away. It wasn't a significantly traumatic injury, but the pain lingered. He got plain films. Those plain films were negative, and he was diagnosed with a bone bruise. Within about 20 days or so, he was reevaluated. And at that time, it was not thought that further imaging was needed, and a cortisone injection was ordered. His pain persisted, as you probably imagined. And he subsequently underwent an MRI and a bone scan. Does anybody know what they found? Turned out to have a navicular fracture. So reportedly cortisone got laid down in an area that had a non-healing navicular fracture in a guy who weighs 280 pounds. Thomas contended that that affected his ability to re-sign with the White Sox, caused him to sign an incentive deal with the Oakland A's, cost him a whole bunch of money. I didn't bother to look how the lawsuit ended up, and nor was it reported in any of the articles I read how much he was suing for. But the point here is that these injuries are not uncommon, as we might think sometimes, and they can be subtle and difficult to diagnose. So you really have to raise your index of suspicion so that we're all on the same page in getting folks back to the activities that they love and desire. And as was mentioned by Dr. Robinson, so stress fractures of the foot are relatively common, and you can understand why when we highlight some kind of foot dynamics later, but we're not going to touch on any of those. We're only going to touch on traumatic foot fractures, and that was by design. So I apologize. We will make mention of stress fractures from time to time. It'll pop up as a topic, but it won't be a focus of any of the things that we discussed today. And also I ask for just a slight bit of charity on your part. So there's a ton of minutia that we could delve into. Obviously, orthopedic surgeons spend 5+ years in training, and then they have fellowship, et cetera. So we could easily get lost in the weeds here. We're going to try to stay out of that. So I understand that I'm going to leave stuff out, but it's 40 minutes and there's a lot of things to cover. So we'll do our best. Anybody recognize this guy who got yanked from Game 6 of the World Series?
Blake Snell.
Yes, I love it. Thank you. Blake Snell got out of the shower in 2019, and he thought that would be an opportune time to move a granite pedestal that he had in his bathroom. He failed to realize that the pedestal was in 2 pieces, and the top part of this granite pedestal fell directly on top of his foot and fractured his 4th metatarsal. So I wish I could make these things up, but it's all true. Let's cover some anatomy real fast. How many total bones are there in the foot? Don't count. 26. So 26, not counting sesamoid, accessory, naviculars, et cetera, et cetera, et cetera. But there are 26 bones in the average foot, right? So if you do the math between the 2 feet, that's 52. 52 is what, roughly a little less than 1/4 of the total bones in the body are in the foot. So lots of ample areas for fractures. And the foot is generally broken up into 3 parts. You got the hind foot that entails the calcaneus and the tailless, and then you move to the midfoot with the cuboid and the cuneiforms, followed by the forefoot with the metatarsals and the phalanges. So while we're not going to talk about stress fractures, any type of fracture of the foot is fairly common because just walking, you're putting about 1.5 times your body weight on your foot. When you run, you can get 5 times or more of your own body weight on your foot. So that stress by itself is enough to cause a fracture, let alone the repetitive nature of it. Another reason why this topic is so pertinent is because 40% of all lower extremity fractures occur in the foot. They may not be as sexy or get as much attention as other fractures, but they're certainly prevalent. There was actually a very recent May of 2020 study out of Denmark that helped gain some insight into the incidence of foot fractures. So I thought this was the best, most recent study on incidence with regard to foot fractures. So 142.3 per 100,000 people per year. So not an insignificant number, although that does pale in comparison. Previous statistics had suggested that perhaps that number was up around 210 to 225 or so. And you can break it down by the location of the foot, right? As you can see, the forefoot has a whole bunch of fractures in it by comparison, and it makes sense as it'll unfold when we talk about that moving forward. 36.1 years old is the average age, active young population, what we often do and like to see in clinic. And the gender distribution is roughly equivalent, 45.7 to 54.3%. But an important take-home point is, in the emergency department, I see lots of fractures due to high energy injuries, car accidents, those types of things. But really in this study, 98.7% of the foot fractures found were low energy. And that's right in our wheelhouse, right? Whether it's hit by an object, a ball, etc., falling off a bicycle, other bicycle injuries, and then sports in particular. So right in our wheelhouse, and plenty of fodder in this subject matter for for upcoming boards if you're in that realm of your training. Now, there are some risk factors that have been identified. The risk factors will vary based on the specific type of fracture, but from a broad-based perspective, these are things that you should keep in mind that set people up for fractures, particularly in repetitive sports. So higher arches tend to lend to that. So does shoe design. So been a lot of things in the news lately about runners being disqualified from marathons, et cetera, for having too much cushioning or too much height on their shoes, et cetera. Shoe design has fundamentally changed that. And you've probably all read various books on the topic, but it does affect the incidence of fractures on the foot. So does vitamin D deficiency. It turns out that the non-dominant foot, particularly in soccer, or as some people call it, footballers, tends to predominate. And then harder play surfaces. So I think often of the old Olympic Stadium in Montreal that, has wreaked havoc on certain players because it was basically a concrete floor with AstroTurf carpet laid down on top of it. And that causes all kinds of problems, just as it would in basketball or other hard surfaces that sports are played upon. And then increased loading, whether that's repetitive or weight muscle. Think about a guy like Zion Williamson, who's built like a tight end in football, but is running up and down the court and coming down on his feet all that often. I guess it wouldn't surprise anyone that he would suffer a fifth metatarsal fracture. If you don't identify this person, then we'll have to stop the presentation, although some of you may be clamoring for that already.
Jordan.
Thank you.
Michael Jordan.
Yes, this is Marcus Jordan. No, I'm kidding. Yes, this is Michael Jordan. So Michael Jordan actually had a navicular fracture back in 1985. Some people have reported this to be a stress fracture. It isn't clear to me that that's the case because it happened acutely. So I guess it could have been cumulative stress, but nonetheless, he did have a navicular fracture in 1985. As an aside, this was repeatedly imaged by CT at Northwestern, and I've heard some of the radiologists who were there in 1985 tell tales about him coming through. Suffice to say, anybody who saw The Last Dance knows that he was not particularly happy with this injury and it keeping him out. There's stories of him returning to North Carolina to play basketball earlier than they had anticipated or wanted. But what I remember most specifically from The Last Dance and him talking about this injury was he was told that he had a 90% chance that he'd be able to heal this and return to his normal basketball activity, and that there was a 10% chance he'd never play again. And he said, "I'll take that chance. I'm ready to play." And the owner of the team, Jerry Reinsdorf, said, "I don't think you understand the risk reward benefit ratio here. If you had a headache and I had 10 pills and I told you that 9 of those pills would cure your headache, but 1 of those pills would kill you, would you take the pill?" And he looked at him and he said, "I guess it depends on how bad the effing headache is." So I think that speaks to the kind of competitor he was. I got a kick out of that story personally. First up, as we go through, so we're going to break this down into hindfoot, midfoot, forefoot. We'll start in the hindfoot. What do you see?
Calcaneus fracture.
Perfect. So we'll start with calcaneal fractures. All right. So these are a high percentage of fractures that are seen overall. Now, they may not be quite as common in sports medicine clinics per se, although I've seen more than my fair share of them. Okay. The thing to keep in mind here is that roughly 1 out of 5 of them are open. Okay. If that's the case, obviously it's a whole different ball of wax. That's a surgical problem from the get-go, but a very high percentage of foot fractures are calcaneal fractures. And they're noteworthy because they tend to take a long time to heal and result in a fairly significant loss of time from whether it be work or sport. And that's despite all of the contemporary means we have to treat fractures. This particular one hasn't really advanced all that much by comparison. About a third of them are extra-articular. Those ones, obviously, as you would imagine, are a little less significant in terms of management or suggesting poor prognosis than the intra-articular ones. The extra-articular ones are kind of the deforming force is the term that's used. So the twisting rotation type of things that can happen. It's more prevalent in younger patients, but that type of force tends to be unilateral, whereas the intra-articular ones can be bilateral and are the more high energy forces. So this is jumping from a prolonged height or a car accident, those types of things. Okay. And from a physiologic anatomic perspective, and I didn't appreciate this till I was doing the research for this presentation, but the Calcaneus actually has a fairly thin cortical shell, which increases its susceptibility to fracture. So you get all that load on the heel with a relatively thin shell of bone, and you're setting yourself up for a fracture. Okay. When you're thinking about these, you need to make sure that you're purposeful and give the best indication possible, because the frontal view of plain films for these injuries can be super helpful. You also want to get a lateral. You saw that on the very first slide. That can give it away. But one of the views that we tend not to get as regular imaging of the foot is the axial view, and that one can really give away the diagnosis of a calcaneal fracture. So if you ordered your standard foot views, AP lateral oblique, you wouldn't necessarily get an axial view. I think that's important to keep in mind when you're evaluating for these injuries. If your index of suspicion for that calcaneal fracture is high, whether it's based on physical exam or the mechanism itself, be sure to include the axial view. And you'll also want to entertain the idea of getting bilateral views. We won't delve into Sever's disease, but the calcaneal apophysitis in adolescence, but you can get a good feel for whether or not that separation is atypical from one side compared to the other by getting those bilateral views. One of the things that, I talk about lots of different fractures in lots of different settings. Emergency department physicians aren't real keen on this next topic, but it's pertinent for us, and it's Bowler's angle. So Bowler's angle helps us decide how to proceed with the management of calcaneal fractures. And it's not really as complicated as it might seem. You simply take a line and you draw it through the highest point of the calcaneus, and the first line goes from that point through the posterior calcaneal tip. And the second line goes from that same high point through the anterior process of the calcaneus. And then you just figure out what that angle is. I know we're all carrying our calipers with us, so that shouldn't be a big issue. It's a joke. But what you want is you want an angle somewhere in that neighborhood of 20 to 40. Okay. If it's outside of that, it's more likely that the patient will require surgery. Although I will tell you that that's not absolute. There are other things that go into it. So obviously skin integrity would kind of trump whether the angle was between 20 or 40. And I've had lots of hockey players and other patients with these calcaneal fractures who fall outside of that realm by a few degrees one way or another, and they've been treated conservatively and do very well. But certainly falling outside of that would increase my likelihood to refer to a surgeon. And this one, I guarantee you, is going to show up somewhere either in the clinic or on a test. So if you have a significant axial load that results in a calcaneal fracture, what other injury do you need to immediately consider? Silence. You guys are doing great.
Is it like lumbar spine?
Yes, you were on it. I knew you were on it. I apologize.
I thought hip. I was thinking like a hip. Like
good thought. Remember that this is an axial load. That axial load, think of like a Mason fracture, right? If you don't break the medial malleolus, that force goes up the syndesmosis and comes out the proximal fibula. Similar, this force is going up and it's going to come out somewhere, and this shows up all the time on tests, right? So this compression fracture of the lumbar spine is pathognomonic. Orthopedic surgeons almost unilaterally, if they're consulted for a calcaneal fracture, will ask for imaging of the spine. I don't know that you necessarily always need to get to the imaging of the spine, but you certainly need to do a thorough examination. And if people have risk factors for these lumbar spine injuries, whether that's osteoporosis, previous fractures, kyphotic deformity, scoliosis, whatever the case may be, strongly consider it and have a low threshold for getting this imaging. Okay. In terms of treating calcaneal fractures, this is where that bulky Jones splint comes into play. So there are various derivations of how to do this, but really it's tons and tons and tons of padding around the calcaneus to help buffer the discomfort. These are super painful because everybody's putting all of their body weight on the calcaneus. So the way that I like to do it is plenty of padding as seen in the picture on the slide, along with a posterior slab and a stirrup splint. I like to cross the stirrup splint in the front as well. Plenty of padding, plenty of stability, it keeps everything in place. Eventually, this will get transitioned to a short leg non-weight bearing cast. The return to function period is somewhere in the neighborhood of 6 to 12 weeks. Although pain can linger after that, but the bone should be healed by then. There are some indications for surgery. I kind of hinted at some, right? So those displaced fractures where the Bowler's angle is off, if they have persistent pain, that may necessitate further imaging, like an MRI or a bone scan. And if it's just simply not healing, then it's going to get fixed as well. Now, colloquially, there's a bonus question. This has a cute little name that's given to it. Does anybody know what it is or why? These are called lovers fractures. It is anecdotally argued that they were early on reported in individuals who were engaged in, shall we say, nefarious behavior with individuals that they should not have been, only to be found out, and in an attempt to escape the situation, jumped out of second floor windows, 2 separate cases, landing on their calcaneus and resulting in this fracture. While that sounds like a wives' tale, I can tell you that I've taken care of multiple patients who, maybe not the nefarious part, but have in fact jumped out of second story windows, landed on their calcaneus, and ended up with this exact fracture. Anybody know who that is?
Darren McFadden.
Darren McFadden, that's great. And if you want a slightly disturbing but mildly amusing YouTube video, go YouTube him at the drive-thru. It's kind of at least somewhat amusing on some level, I guess. I don't condone the behavior, by the way. So Darren McFadden, back in 2011, in a fairly innocuous play, they were playing the Chiefs. He caught a pass over the middle from Kyle Bowler and planted his foot, pushed off, and suffered a Liz Frank injury. They said his foot was structurally fine. Well, that's clearly not the case with the Liz Frank injury that we'll talk about later, but he seemed to get back on track and ended up doing fairly well with the Cowboys thereafter. Anybody identify the fracture shown here?
Tailless.
Very good. Tailless fracture. The title on the slide probably helps. All right, so these are relatively infrequent, but the thing to keep in mind is that the talar neck accounts for about 50% of all of these. And otherwise, body fractures are at higher risk for avascular necrosis. It's a watershed area for the talus. And so if you see a body fracture, you have to be acutely aware of that. Twisting injuries themselves tend to cause an avulsion, whereas if you suffer a severe dorsiflexion injury, that's where the talar neck comes into play. You can actually dislocate that fracture fragment into the joint posteriorly, which can cause an interesting physical exam finding that we'll find later. Meanwhile, so we talked about axial loads with the calcaneus fracture. Those can injure the talar body and then predispose the patient to potentially avascular necrosis. So always be aware of any other risk factors that may play into that. I mentioned it just a second ago. With this posterior fragment dislocation, that ankle joint will actually lock for patients. So if they get locking or significant clicking that's particularly painful, your index of suspicion should be higher that there may be a fracture fragment that is broken off the talus and stuck into the joint. Okay. Now these injuries can be subtle. All right. So one thing to keep in mind is pay particularly close attention to the oblique views. They can pull them into view a little bit better. About 30% of the population, give or take, depending on the study you read, will have an os trigonum. So you need to make sure that you're not identifying the os trigonum and you're actually looking for an acute fracture. I think you guys are all far smarter than I am, so you're aware that well-corticated, rounded structures tend to represent os bones rather than acute fractures. But these are injuries that may necessitate a CT. They're particularly helpful in following healing, especially of talus stress fractures, which tend to be a bit more common than traumatic talus fractures, but that would be the indication, is if your index of suspicion is high and or you're following healing, whether that's in the clinic or out of the training room. Okay. So this lateral process of the talus, so this is good board fodder as well. So when you see a lateral talus fracture, what is this called, or who does this happen to commonly?
Snowboarders.
Yep, love it. Great. Thank you. So this is snowboarders fracture. So almost not unheard of, but super rare prior to the popularity of snowboarding. And so if you see someone come in with ankle pain after snowboarding, you should pay particularly close attention to that lateral process of the talus. In terms of treatment, you don't have to put on a Chuck Taylor cast, but short leg, not weight bearing cast is preferred. Slight bit of Aquinas is nice, helps to keep things for the most part lined up. So particularly when there's an avulsion. This is a 6 to 8 week cast in terms of healing. And then folks are generally, depending on when the cast comes off, they're back to activity within 8 to 12 weeks. Now, keep in mind, because of the articulation, patients can be stiff and painful afterwards. That can be worked out with physical therapy. The indications for surgery, there are always some, right? So if they're significantly displaced or comminuted, so crush injuries in particular may require it. If there's a large avulsion injury, and then if the intra-articular talar head is involved, and remember, 2/3 of these are intra-articular. So if you see that, the likelihood for surgery is higher. Anybody see a problem with this x-ray? It's a subtle x-ray, but it's one you'll see. So if you look at that medial talar dome, do you see that? So not as well corticated, slight divot there, not as dense, okay? So OCD lesions, there's a bit of artistic license. Is this a fracture? Is this a cartilage injury? We're gonna go with it because I think it warrants discussion, right? Because traumatic injuries to the lateral talar dome do result in fractures. These tend to be more difficult to see. Now I've picked some that are a little more obvious to view on the slides, but they are often superficial and a bit smaller than their medial dome counterparts, but they're important to note because they don't heal as well, particularly spontaneously. On the lateral talar dome, they are more likely to be displaced and cause significant discomfort, so keep that in mind. The mechanism of injury here, aside from axial loading, is you can get an inversion injury of the ankle with some extreme dorsiflexion during that axial load, and that'll just shear that off, and that shearing mechanism is what makes it superficial and smaller. On physical examination, things to look for that may tip you off to there being a lateral talar dome injury even before you get plain films. Look for a joint effusion. Can be difficult to discern in the ankle. I'm well aware of that, but keep a close eye out for that, and then look for high arch or cavus hindfoot that predisposes folks to having lateral talar dome fractures. These are ones where weight-bearing plain films are particularly valuable. If your index of suspicion is high, and mine has been several times in the clinic and in the past, you can get a CT scan, but if you're concerned about cartilage involvement as well, they tend to be less reliable. So you want to roll over to an MRI. Thing to keep in mind here is that MRIs can often overestimate the degree of injury. You get some surrounding edema that may not be necessarily related to the injury itself, but they are very sensitive in picking these up. So if you're concerned about it, this is a perfectly appropriate image. And if that doesn't show it, or you would prefer, bone scan does have a role here. It is slightly more sensitive, but it's probably dealer's choice on that one. It does have good specificity though. So that's a good indication for securing a bone scan. In terms of treating these, so non-weight bearing for 6 to 8 weeks is often the first line treatment, but I'd love to report better outcomes, but about 45% will report good to excellent outcomes. So those numbers aren't super high. There are indications to phoning a surgeon, right? So these chronic lesions at 4 to 6 months out that aren't healing, if that chunk is displaced and freely floating, or the fragment itself is greater than a centimeter, the one shown in the image here is a huge talar dome osteochondral defect. And then even if you have a small fragment, but it's mostly cartilage and there's minimal bone there, the thought is, the research suggests that that doesn't do well in reattaching and healing because there isn't a lot of bone substrate. And so those should be considered for surgical referral. Who you see here?
CJ McCullum.
I love it. Excellent work. So CJ McCullum actually this year during the season suffered a fracture of his lateral cuneiform. I think it happened during play. It isn't quite clear. There was no video that I could show of it, but he did have a lateral cuneiform and missed some time this year as a result of that fracture. What fracture you got here?
Navicular?
Love it. Yeah, see, the titles help just as a clue. But yeah, navicular fracture, you can see it kind of front and center, that big chunks hanging off the navicular. Okay. There are 4 types of navicular fractures. There's a dorsal avulsion injury, tuberosity, body, and then stress. We won't focus on the stress one, obviously. In terms of the dorsal one, this is usually an eversion or twisting injury with the foot kind of plantar flexed. I showed Joel and beat up there because he, early in his career, he had a delayed start to his playing time in Philly because he had a navicular fracture as well. The body gets injured when there's hyperextension with then extreme flexion, oftentimes with a rotational component, although it doesn't necessarily have to be. And then I mentioned the middle third of the bone. So the middle third of the navicular is a watershed area as well. And this is an area that is not only at risk for stress fractures, obviously, but delayed healing as well. So you can get non-union or malunion in this area just because of the tenuous blood supply. In terms of imaging, so standard plain films are generally sufficient to find this fracture. You'll get good views of the navicular with the AP, lateral, and oblique series. But you do want to make sure that you're paying close attention to the accessory bones. They can throw you off, but again, well corticated, rounded bones give them away as accessory bones. Okay, but the one thing you want to keep in mind, we like to see fractures in 2 views to confirm that. Body fractures are very tricky that way, and sometimes, particularly with the oblique view, you may only see it on the 1 view. So you want to go ahead and treat it as such if they're painful there, even if you only see it on 1 view. And if you're so inclined, further imaging is completely appropriate. So a CT scan would be sufficient because you're not really particularly concerned about any ligamentous injury necessarily at that point. Treatment is controversial, I suppose. So some folks will say, so like IFE's textbooks on fracture management will say that you can let them weight bear, ortho bullets, wheelless. Numerous other studies would suggest non-weight bearing. I'm going to err on the side of non-weight bearing on this one, particularly because of the tenuous blood supply in the body of the navicular. Stress fractures are a completely different animal. Those should be non-weight bearing. This is a 6 to 10 week healing injury. Mileage may vary depending on other risk factors, vitamin D, etc. And then indications for surgery, because I think it's important to know when to call a friend. Okay, large and displaced fracture fragments, those involving something like 1/4 of the articulation warrant a call to a surgical colleague. So tuberosity fractures with displacements greater than 1 centimeter. Or displaced body fractures themselves. And then if they have persistent pain of an avulsion injury, those will often be evaluated for surgical intervention as well. And as we cruise through the remainder of the midfoot, do you see a fracture there? That one's apparent.
Cuneiform fracture?
Yeah, good guess. You're close. That one's a cuboid fracture, ice cube, cuboid. It was a stretch, but I gave it a shot. I'm a dad. I got to have dad jokes. So we're going to kind of lump cuboid and cuneiform together. I think you'll see why. All told, both fractures, cuboid and cuneiform, are relatively uncommon. It's often a direct trauma-related injury. Now, you can get a compression fracture of the cuboid. So if the navicular tuberosity fracture results in a downward force and compression, you can kind of crush that cuboid. So something to keep in mind. But really, if you see this fracture, you should have a very high index of suspicion for other fractures. So for instance, the navicular tuberosity fracture, but also subluxations and dislocations within that midfoot portion. There is a special fracture that'll show up at some point in time in your careers, whether it's on a test or in the clinic. So if you get a crush injury between the calcaneus and the 4th and 5th metatarsals, what's that called? Really popular around Christmas. That's a nutcracker fracture, and that's what you see in this image right here. So that's depicting a nutcracker fracture. That's what it's called. So probably because of the crush injury nature of the fracture. Okay. And then we'll just segue right into the cuneiform fracture. So these, again, medial, middle, and lateral are all uncommon in isolation. Their typical mechanisms include direct impact and then axial loading with dorsiflexion or plantar flexion, either one. And then if your foot's in plantar flexion and you rotate about it, you can get one of the cuneiforms to kind of fracture or suffer an avulsion injury. Now, whether it's the navicular, the cuboid, or the cuneiform, any of those parts of the midfoot, there is an increased risk for acute compartment syndrome. So you should think about that and it should cross your mind. I know we tend to think about it in the lower leg or even the forearm, but it can happen in the foot. So you need to keep that in mind as well. Overall, the complication rate for cuboid and cuneiform fractures is fairly rare, although there is one exception that we'll touch on here. Again, imaging is not too complicated for these fractures. You should be able to see them on most standard imaging, but if there's persistent pain or high index of suspicion, you'll segue right to a CT scan. In terms of treatment, posterior slab splint is generally sufficient. And because they don't tend to bear a lot of weight, you can get away with short leg walking casts for these people, and that duration of that is about 6 weeks. Obviously, if they have pain with such a short leg walking cast and you want to give them crutches or tell them to just stay off it in general. But the one thing to keep in mind is that there is one significant long-term cuboid injury complication. Does anybody happen to know what it is?
Could it be avascular necrosis?
It's a great thought. So that is excellent thought. For the cuneiform and the cuboids, they have decent blood supply, so it tends not to be that. But you can get impaired function of the peroneus longus tendon, so it can get caught up in scar tissue or other bony healing. So something to keep in mind moving forward regularly if there's difficulty with movement of the foot after the healing of the fracture. And who's your boy?
Cam Newton.
Cam Newton. He's looking for work. If you need a quarterback, he's your guy. So he had a Liz Frank injury in 2019 as well. And we'll segue right into the
Liz Frank.
love it. Liz Frank injury. Very good. Okay. So these are missed at least 25% of the time in the emergency department. The data doesn't suggest it's that commonly missed in the clinic, but when studied there, this is frequently missed because it's just not something that's always looked for. So always keep an index of suspicion for this one as well. So this Liz Frank joint is between the first and second metatarsals in conjunction with that medial cuneiform. And what you're really looking for is disruption of the second metatarsal and the medial cuneiform. Those should line up, and it's called the keystone. So the second metatarsal should fit nice and neatly right on top of the medial cuneiform. This injury dates way back to soldiers. Some people have said in Napoleon's army, but some people have argued that it was soldiers who would fall off their horses and their foot would get stuck in the stirrups and it would twist and they would suffer this injury. Others have said that it's when the horse steps on them after they fell off of them. Either way, this is a kind of localized high energy rotational force or a crushing blow or both, I guess, if you're having a really bad day. In sports, it tends to happen when you fall or you get an extra force on your plantar flexed foot. So that's what happened to Darren McFadden, for instance, right? He planted his foot, he flexed it, he got hit, he got extra loading on the kind of midfoot, forefoot, and suffered the Liz Frank injury. In terms of physical exam pearls, I'm going to throw a couple at you. You probably know some of these, but we'll give it a shot anyway. So if you grasp the metatarsal heads and apply a dorsal force to the forefoot while feeling the tarsal metatarsal joints, if you reproduce pain at that Liz Frank joint, high index of suspicion for a fracture. Specifically, if you notice there's subluxation dorsally, that's an indication of instability of that joint. And then if the first and second metatarsals can be displaced both medially and laterally, then the patient has global instability, and that's almost always an indication for surgery. You can also look for pain with pronation and abduction of the forefoot. So if that reproduces pain in or around the Liz Frank joint, then you should be concerned for that injury. And then lastly, this one's fairly simple, right? So if you plantar flex the great toe and you abduct it and reproduces pain up at the Liz Frank joint, you have some increased concern for that injury. But just one other physical exam finding that you don't really have to remember the technique for can be indicative of a Liz Frank injury. Does anyone know what it is? So significant plantar arch ecchymosis is highly suspicious for Liz Frank injury. So keep that in mind. Lots of bruising, pain there. You should proceed as if it were a Liz Frank injury. These are folks that need weight-bearing plain films. That's why I think often it gets missed in the emergency department. There's no stress there to spread it out. And what you're looking for specifically is you want the medial edge of that second metatarsal to line up with the medial edge of the middle cuneiform. If that doesn't happen, then you should be very concerned. This particular image shows flex signs, so you can kind of see this little fleck of bone right here. And that fleck is indicative of a Liz Frank injury as well, and should lead you to get further imaging. And that imaging should be an MRI because the data evidence suggests that it's more sensitive and specific to identify Liz Frank injuries. And keep in mind that you want to know about the ligamentous attachments in the region as well. That offer some semblance of stability, even though this is a largely unstable joint. In terms of treatment, some folks can be treated non-operatively. They get casted for about 8 weeks. They should be in the camp that have non-displaced injuries that are stable with weight bearing. So on their imaging, they don't spread out. You can't get them to pull apart, et cetera, on physical examination. Now, the research would also suggest that these folks tend to have decreased function and mobility in the long term, although that's not always the case, obviously. There are different options for surgery, okay? So some get pinning, and those are the ones that are displaced with a lot of soft tissue swelling. The ones that get ORIF tend to have more than 2 millimeters of shift on those weight-bearing plain films. And then some folks have argued for arthrodesis. This is controversial. I'm not going to touch on it because I'm not smart enough to detail it, but it is noted in multiple papers to be controversial. And we're coming down the home stretch, so we're into the forefoot. What do you see here?
Second and third ray fractures.
Yeah, metatarsal fractures. That's so meta. That's what all the kids are saying nowadays. Okay. These are typically direct crush injuries, usually with the forefoot flexed, and then some semblance of rotation about the hind foot or the leg. Some interesting epidemiologic facts, right? 4 years old and younger tend to have first metatarsal fractures, and the third metatarsal rarely gets fractured in isolation. So if you see that, you should have some level of concern for associated fractures in the second and or fourth metatarsals. In terms of imaging, this one's fairly straightforward, so we don't need to belabor it too much. Standard plain films, again, AP, lateral, and oblique, almost always show these, okay? CT scans, MRIs, bone scans, etc. very rarely show it, and there's a role for ultrasound. So ultrasound can show these as well, particularly if you're used to seeing cortical disruption. But advanced imaging can be helpful if you're assessing for persistent pain and concerned about non-union or malunion. In terms of treatment, most of these are treated non-operatively. So particularly non-displaced first metatarsal or isolated and minimally displaced second through fourth metatarsals. But there are important caveats to consider. These are relatively uncommon, but if you break multiple bones, multiple metatarsal bones, that is, those often get fixed. There's not enough stability there. If there's a lot of translation or overlap or a significant amount of rotation, those fractures also will be considered for surgery. It doesn't necessarily mean that they will, but those are the indications that they're looking for according to the literature. You all see the problem here, front and center.
Sesamoid, bro.
I love it. Thank you. I appreciate the interaction. It makes the Zoom presentations all the more enjoyable. This is a sesamoid fracture. Now, I know most sesamoid fractures tend to be stress fractures, but that's not always the case. Particularly for the tibial sesamoid, that can be the result of traumatic injury as well. It's more commonly traumatically fractured. It tends to be larger than the lateral sesamoid, and in terms of mechanism of injury, think axial load with hyperextension. On physical examination, if you hyperextend that toe, you can worsen the pain. But you do want to have in the back of your mind the bipartite sesamoids, because somewhere between 10 and 25% of the population will have that. And 97% of bipartite sesamoids are lateral. And then to make things even a little more complicated, about a quarter of the population will have bilateral bipartite sesamoids. So you got to keep that in mind. These can be really difficult to pick up on plain film. So you'll either want to consider comparison views with the other foot, or look at an MRI to assess for edema, particularly if there's persistent pain there. If the diagnosis remains in question, you can proceed to a bone scan. And that's particularly the case if you've gone through conservative management and they haven't improved. Okay. not that anything in sports medicine is easy, or life, I guess, for that matter, but upwards of about 30% of asymptomatic patients can have edema in the sesamoid bones on imaging, whether that's from walking, running, other recreational activity, et cetera. So keep that in mind. It can be a little bit oversensitive in that regard. In terms of initial treatment, this is a activity modification, orthotics, pad around the sesamoid NSAIDs proposition. There are some folks who have contended that short leg cast with extension of the toe, although the data doesn't necessarily support it robustly. So I won't endorse it fully, but I bring it to your attention because it has been mentioned. Surgery happens, but it's not generally an acute intervention. Some research has suggested up to 12 months of operative failure before they'll excise that sesamoid bone. I guess it depends to some extent on what level of activity you're engaged in and how significant the pain is. And that is
David Beckham.
David Beckham. I knew you would get it. So back in 2002, he suffered a second metatarsal fracture, and soccer's everything, particularly in Europe. And so he made the front page of the Sun, and they wanted people to lay hands on him to heal him. I don't think there's any in double-blinded randomized control trials that showed that anybody's hands were effective in healing it. But with that said, next up, that's Jones fracture. Okay. So Jones fractures get a lot of buzz, and it's probably the most well-known fracture of the foot that we would talk about today. These are considered unique compared to the other metatarsal fractures, which is why I pulled it out, and we'll talk about it for a second. Okay. True Jones fractures involve the metaphyseal diaphyseal junction. Now, there's 3 zones, and I've gone away from using the pseudo-Jones nomenclature. It's still in the literature. You can still find it in textbooks. Pseudo-Jones refers to the zone 1 fracture primarily. I don't like that. I prefer the zone 1 because pseudo-Jones, in the back of my head, kind of downplays the significance of the fracture a little bit, and I don't like the mixed metaphor. So I like to break it down into the zones, and those are approximate, but it's really the tuberosity there of the 5th metatarsal, and then the middle port, and then as you move up toward the diaphysis, you get into zone 3. Okay, these usually happen by sudden force under the lateral aspect of the distal 5th metatarsal. Sometimes landing on the side of your foot can cause a similar injury as well. And the reason why these are treated differently is because the blood supply is a little bit more tenuous. It gets a bit better when you get out into zone 3, but zone 2 is this watershed area, again, much like we had talked about in the Tailless, for instance. But that zone 2 sets itself up for poor healing, whether it's non-union or malunion. So those ones you have to pay particularly close attention to. The nice part is making the diagnosis is not necessarily terribly difficult. The AP lateral oblique views of the foot, again, proved to be sufficient. But one thing you want to look for, particularly on that lateral view, if there's a wide gap on the plantar surface of the foot with regard to the fracture, that can portend a poorer prognosis in healing. So that may change your management a little bit, particularly if it starts to work its way down towards zone 3. You don't generally need CT scans for this, but it can be used to evaluate for healing. I mentioned that's how they reportedly to me followed Michael Jordan's healing of his navicular fracture. So similar thing with the Jones fracture. MRI and bone scans are generally reserved for stress injuries. You don't generally need them for acute Jones fractures. Non-operative treatment does have a role here, and weight bearing as tolerated is acceptable for zone 1 fractures. As long as there's not a lot of rotation with that fracture, zone 1 can be treated just with a post-operative shoe, and it can walk as tolerated. Sometimes in the acute phase, you need to give them crutches, etc. But if you don't have to boot them, don't boot them, because that obviously increases the risk for other complications such as deep vein thromboses. Union usually occurs in these by 8 weeks, although there is some data that suggests that for several months afterwards, they can continue to have discomfort at the site of that zone 1 fracture, so keep that in mind. In terms of protected non-weight bearing, so casts for 6 to 8 weeks, these are zone 2 and 3 fractures in recreational or non-athletes, 2 separate categories. So regular non-engaged in sports folks will get these fractures as well, as you can imagine. Those folks can be treated with casts for the most part, but your high-level athletes, especially in zones 2 and 3, often will have what's depicted here, a screw or other fixation, because of the risk of non-union. There is some evidence to suggest that the rate of non-union or refracture of zone 2 injuries is as high as 33%. So that's a fairly significant risk, and that's why folks are quicker to fix these. And the number of professional athletes who have had Jones fractures surgically repaired is quite lengthy. And I'll give you a quick word on this fracture. Does anybody know what this one's called colloquially? He's one of Santa's reindeer. So dancers fractures. Now, it's interesting. If you look on the internet and did a Google search for dancers fractures, there's plenty of folks who will reference avulsion fractures off the base of the 5th metatarsal. My teaching to me and subsequent reading is dancers fractures are really further down the shaft of the 5th metatarsal, typically found about 1.5 centimeters away from the tuberosity. And they're a little unique because they tend to be spiral fractures extending into that distal metaphyseal region. And part of the reason they're called dancers fractures is because they happen when a dancer gets into the demi-point position. So I am not a dance medicine provider. I wish I was more insightful in that regard, but this is historically where it comes from. But it also occurs when you come down from landing at a height. So if you don't land on your calcaneus, you put your distal 5th metatarsal at risk. By and large, they're treated very similar to metatarsal fractures. So you can let them weight bear as tolerated. However, you do want to consider reducing and splinting these if there's 10 degrees of rotation, angulation, or greater than 3 millimeters of displacement. So those are the general indications to fix these. And then lastly, if they don't heal, and a fracture such as the one shown here is going to have a difficult time healing, most likely. So if you can't keep it reduced or it doesn't heal with casting, percutaneous pinning or plate and screw fixation may be necessary.
Kevin Durant.
Kevin Durant has had a few injuries. He obviously injured his Achilles, but he sustained a Jones fracture in his foot in 2014. He had his surgically repaired as well. Final topic before we bounce out of here. Phalangeal fractures. All right, these ones are straightforward. There's not a lot to it, okay? So almost always stubbing injury of the toe or a crush mechanism, whether it's dropping something on your foot, etc. Sometimes you can get a hyperextension injury, although that's a lot less common. The one pearl I'll give you with phalangeal fractures, if you really want to help a patient and they have a subungual hematoma, feel free to drain it. You don't need electrocautery to do this. My preferred method is to take an 18 gauge needle after using chlorhexidine or alcohol to cleanse the top of the toenail and make a few small sort of like burr holes in the top of the nail and express the blood out if it's acute. Obviously, if the 24-hour plus window is passed, that blood's going to congeal a bit and won't drain. But if you can drain the blood out from underneath this, you're going to make the patient feel a lot better by relieving that pressure. And within 24 to 48 hours, patients often feel significantly better. Obviously, that's not always the case, but oftentimes it is. And then there's no special imaging that's typically needed for these. Plain films are generally sufficient. Treatment for 2nd through 4th fractures, those can generally be buddy taped. And you can do it any number of ways. I like to wrap them around and then cross them at the end just to provide a little bit of extra stability at the base of the toes. It depends a bit on which phalangeal fracture you're talking about, I suppose. But the one caveat there is the smiley face great toe fracture. Those are typically casted. They are more likely than their counterparts to result in needing a surgery because of their roll and balance and their increased loading with ambulation. And that's particularly the case if they're intra-articular. So low threshold for that. Somebody has to know who this is.
George Brett.
George Brett. He was in the clubhouse in 1983 when he heard his friend Bill Buckner was at the plate. And while running through the clubhouse, he kicked a door jamb and broke his one of his fifth phalangeal bones. So he missed a significant amount of time for that. So it's not just the data, it happens in real life, kids. One more bonus question for you. What tool can help you detect a fracture on physical examination?
Tuning fork.
Love it. Don't be afraid to use it. I've picked up, I'm not that bright. I've picked up fractures of distal femurs in the emergency department with the tuning fork because their story just didn't make sense. And I didn't pick up the fracture with it, but it at least raised my suspicion enough to get a CT scan. I've done that with foot fractures, with tibial stress fractures, etc. The tuning fork's pretty helpful. Now, it's not very specific, so the specificity can be in some studies down to 15%, but its sensitivity is 75 to 92%. So do all of the studies justify it? No, but it doesn't cost you anything. You don't need to, carry a fanny pack to have a tuning fork. If it's just in the clinic, you could use it. So don't be afraid to pull it out and add that to your repertoire. If you don't see something on plain films, that may spur you to get further advanced imaging, which isn't always indicated, as we've discussed. And our last famous person, does anybody know who this is? This just happened last Thursday.
Casey Horn.
I love it. So this is Joe Horn's son. Joe Horn's the wide receiver for the Saints who pulled his cell phone out of the goalpost way back in the day. So JC Horn was literally just in pass coverage. You'll see him right at the top of the screen. And all of a sudden he plants his right foot and it just buckles on the 20. Just gives out from him. That's not a stress fracture. He broke, reportedly, I haven't validated this, but according to reports, he broke 3 bones in his foot and may need season-ending surgery. And that was a fairly innocuous mechanism, but you're running, you get 5 times plus your weight on that foot can just go like that. So I'll leave this up here for a second. What I did was I made some take-home points, just the 10,000 foot view, important points for each of those areas of fractures that we discussed. And I understand I didn't talk about tough fractures and a few other things, but with the time that we had, I thought I'd pick out the highlights and hopefully that was of some utility. So in reflecting upon the presentations, I think I at least addressed all those. I'm not sure if anyone laughed because I can't see you all. And if you're throwing things at your screen, it's well-deserved as well. With that,
you've already won me over.
We'll end on Alanis Morissette.
Don't be alone if I fall. Head over feet. And don't be surprised if I love you for all that you are.
All the image credits are there. I am happy to send that out as a PDF file if anybody wants to see it, just so they can look at the pictures or review the bullet points. I'm happy to do that at any point in time. And with that, if anybody has any questions, I'm happy to take them.
Yeah, thank you very much. That was fantastic. A great overview. That's a lot to have to cover in an hour. Great job. So one of the questions was in regard to draining the subequal hematoma, if you should x-ray first to prevent the risk of causing an open fracture.
Great question. So that delves into the world of tough fractures, and tough fractures are technically open fractures, but aren't treated like operative fractures in that regard, barring some significant loss of tissue. So when you do the subequal hematoma, yeah, I tend to get the x-ray first, but I'm not worried about creating an open fracture, because literally when you take that 18 gauge needle, so you take the sharp one, not the beveled one, and you just slowly twist it in there, you actually shouldn't penetrate that, because as soon as you see blood come back, you just stop and you know you've released it. So your risk of causing a quote open fracture in that regard is quite minimal. Good question though.
Another question, can you speak to how you utilize the tuning fork to investigate for possible occult fractures?
Yeah, great question. So the tuning fork so the foot has all these superficial tendons and muscles. And so it can be really difficult to discern whether or not you're pushing on a tendon or you're pushing on the foot. And even if you isolate the motion, right, so your common perineal tendon and your resisting eversion, et cetera, it can be very difficult because that tendon is still pulling on a bone that could be broken. So what I like to do is just take the tuning fork and put it right on the bone and see if that exacerbates their pain. And if you've seen anyone who has an occult or subtle fracture that doesn't necessarily show up on x-ray and you send vibration through it, it drives them crazy. even people who have high thresholds for pain, they'll tell you when they do, but they light up pretty quickly. So I like to use it that way because it really shouldn't aggravate a tendon or a muscle. It should just irritate the bone, and they'll feel it all the way through the bone, and particularly at the site of fracture. So if you can find the point of most tenderness and put it right there, you'll really get a response out of the patient.
And then the next question, any situation where you would allow someone to be in a boot or a walking cast for a true Jones fracture?
For a true Jones fracture, they'd have to, so there are always those patients who are just not simply surgical candidates. So those folks you toss out. The research would tell us that the zone 2 recreational athletes would be fine. I would suggest that older population folks. So for me, think about the folks that you consider non-operative Achilles treatment to, right? That group of population, the folks that don't need that extra 2 to 5% of power that they lose by not having the surgery, right? And so those folks are the ones where I would say, okay, let's give it a shot and give them the realization that this may end up with a surgery as well. The problem is that for that type of fracture, the recovery is probably longer. So you have to keep that in mind as well. So that the zone 2 fractures in folks who aren't particularly active or athletic, those would be the ones I would consider, but I wouldn't carte blanche do it for all
of them. And then somebody has a question about during game coverage, are there subtle signs to look out for to diagnose a foot fracture if the athlete's able to ambulate?
If they're able to ambulate and perform at full speed or close to it, I think you can let them try. Obviously, this kind of the spectacle of the whole thing, the worse it looks visually, then you may want to pull back on that because sometimes adrenaline is high. I would caution you about putting them right back in and maybe give them a minute to let the adrenaline subside and then perform an exam that way. There are some sports where you simply don't have the luxury to do that, baseball being one of them. Your decision is your decision. But if they can kind of run, plant, cut at full speed and don't have significant pain and there's no favoring, I think you can entertain it. Are you going to make it significantly worse? Maybe, but it would seem unlikely if they're able to do that. Great question, though. Those are the tough ones.
This one had a question about if the fifth metatarsal kind of extends over multiple zones, what classification do you default to?
Always the worst one, because that's the area where it's least likely to heal. So if it crosses 2, treat it like a 2.
And then I think we have a time for a couple more. So this one question about the Frank Thomas case is, would you recommend using pain to palpate on physical exam to determine further imaging, or besides also having a high clinical suspicion?
So let's pull, so I don't want to get myself in trouble with this one because I know the team that takes care of him very well, and they're fantastic doctors. So I can't speak to the specifics of that one, but let's just talk about something for a second because this is difficult. When it comes to professional athletes, they're obviously no better than anyone else, but I can tell you that the threshold to advance image any of those folks, the threshold is just 0. It's basically non-existent. If there's any concern whatsoever, especially in today's day and age when folks have a lot of money invested in those players and their health and well-being, they're getting imaging all the time. And so what we need to dial it back to is when you're, I help take care of a college and high schools, et cetera. Those are the types of athletes that we really should focus on because you can't just pull the trigger on all of those folks. And then I would tend to err on the side of caution, meaning if they continue to have pain with weight bearing, I may not pull the trigger on advanced imaging right away. So within the first week or 2, but if it persists after that, then I'm going to say, okay, well, in this case, I'm not so much worried about a ligamentous injury. Let's get a CT scan, all right, because then we can see the bone. I don't often jump to the bone scan. I'll be completely frank. I've ordered plenty of them, but it's not something that I jump to quickly. I'll get a CT scan, or if there's concern for associated ligamentous injury, I'll let that acute period of 1 to 2 weeks go by, and if their pain persists, that's the time when I would do it. If my index of suspicion is really high, like the tuning fork test or their Liz Frank testing, whether it's the instability test or the abduction and the plantar flexion, if those things are really setting me up right away and their mechanism seems to fit, then I would probably do it sooner. The Frank Thomas case is difficult because his mechanism of injury, as described, is really fairly innocuous, right? He's just a big human being who puts a lot of stress on it. Maybe at the second evaluation, you pull the trigger and get the imaging. It's hard to know. I'm not second guessing anyone. I wasn't there, but that would be the window where I would think about it.
I think also too, one of the things is that, remember what are your high risk fractures and lower risk. And those, so if it's like, if they're very tender over their cuboid, that's maybe something you could sit on for a little bit. Right. If they're very tender over the mid body of the navicular, you may want to, go to the higher imaging quicker, because that is a high risk injury in and of itself, or like a talar neck, concern for talar neck fracture or something like that. Because if you let those people walk around on it, then it could drastically delay healing. So, but we all want to be a good steward of medical resources, in the same way. But you also have to think of making sure you don't miss something that is really important. And
keep in mind that it's not missing it if you make them non-weight bearing and reassess them in 1 to 2 weeks, right? Don't take that mindset into it. Otherwise, every patient I see who has chest pain, well, I better send them to the cath lab, right? Because I don't want to miss that. And it's an extreme example, but don't take away from whether it's foot injuries, knee injuries, shoulder injuries, doesn't matter. You don't have to order that test right away. Protect them if the diagnosis isn't clear. Protect them from themselves and other activities that can make it worse. And then you can reassess them. If you don't, you'll all do a great job of taking care of your patients. And if you follow up with them and do the right thing in that regard, you're not missing anything. You're doing it appropriately.
Great. Well, I think that's everything, everybody. The link for the survey is in the chat. Please fill out that so we can have feedback for future lectures. And thank you very much for your time. And that was a great lecture. And I think we're good for the night. Everybody have a great night.
Thank you all very much. I appreciate your time and participation.